Right, so as we are 3 minutes past 12, I'm going to start now. So thank you very much for joining this webinar. Just a few housekeeping information before we start. So as attendees, you will not be able to share your audio or video feed, but please do post any questions that you would like via the Q&A session, via the Q&A panel, and we will try to ask all or most of the questions to our speakers. Please also note that this webinar is being recorded and live streamed via YouTube, so there will be an opportunity to listen to it again. Next slide, please. So today, day one of the conference, we're going to present the reviews, the rapid reviews of the Uncover on schools and ethnicity. And next slide, please. I'm going to first give you an overview of the day for today. We will start with our keynote speaker, Professor Linda Bauld, and I will introduce Linda in a minute. And then we will have the schools review that will be introduced by Dr. Amir Kirolos and presented by Wei Xu and Zhongyu Lang. And then we will have the ethnicity review, which will be presented by Gwenetta Tari and presented by Kayla and Perna. Next slide, please. Before we start, I just want to give you some information about Uncover. So Uncover was put together at the very beginning of the pandemic, and we mobilized an interdisciplinary volunteer workforce of staff, students, alumni, and emeriti. And the main aim of Uncover was initially to produce rapid reviews, rapid evidence reviews, and also we put together a register of reviews that were conducted or that they are currently ongoing. At the moment, the registry includes more than 1,500 reviews. We used our rapid reviews to inform SAIDS, the Scottish government, and other organizations. We put together a website, and we have formed quite a few external links with other COVID-19 related groups and organizations. There is a website that you can visit where you can find all of our published reviews and also the registry of the ongoing or completed reviews. Next slide, please. One of the most important things that we achieved with Uncover was this very nice staff and student interaction. So we had more than 30 students, volunteers, and these were master's students, PhD students, medical students, that worked along staff during the Uncover phase 1. And students benefited from weekly literature searching, from methodology workshops and career development workshops. There was also a very nice student-to-studio video from Uncover students that was produced and was showed to new University of Edinburgh students that was about keeping them safe and acting responsibly when we return now to a campus again for semester 1. And obviously, this conference is one of these outcomes where all of our brilliant students have the opportunity to present the work they did with Uncover. Next slide, please. This is a snapshot of all of the participants of Uncover, includes our staff and students and everybody that took part or is still working with Uncover. Next slide, please. And now that brings me to our keynote speaker for today. So Linda Bauld, Professor Linda Bauld is the, sorry, apologies, I want to bring this up, is the Bruce and John Asher Chair in Public Health in the Asher Institute at the University of Edinburgh. Linda is a behavioral scientist with a PhD in social policy, and her research focuses on two main areas: the evaluation of complex public health interventions, and also how research can inform public health policy. Since 2014, Linda has combined her academic role with a secondment to Cancer Research UK, where she holds the CRUK Bupa Chair in Behavioral Research for Cancer Prevention. Linda is also a former scientific advisor to the UK government on tobacco control, and currently she advises Health Canada and the World Health Organization FCTC Secretariat. She is a fellow of the Royal College of Physicians of Edinburgh, the Royal Society of Edinburgh, the Academy of Social Sciences, and the UK Faculty of Public Health. During the COVID-19 crisis, she has served as a member of the COVID-19 Rapid Response Funding Panel for the Economic and Social Research Council. She has coordinated the Usher Institute's COVID-19 webinar series and regularly appeared in print and broadcast media to discuss key developments during the pandemic, as well as measures that have been taken to address COVID-19. So thank you very much, Linda, for joining us today, and we really look forward to your presentation.
Thank you very much, Ilvi. I really appreciate those very kind words. Can you hear me okay? Great. So I don't have any slides, colleagues. What I agreed with Nea and Avi that I would discuss today was why behavioral science can be useful to support governments, decision makers, and the public in terms of our response to the current crisis. So I've just taken a few notes. I'm just going to speak for about 15 minutes or so and try and set out some parameters for why behavioral science is useful. It probably also relates to some of the topics you've been looking at in the Uncover reviews. And then maybe also reflect on a few examples from the UK in recent months that I think highlight some of the aspects of behavioral science. And then if I remember, I'll say something about research funding, which of course is really important at the end. So I think most of you are familiar with what behavioral science is, although there's a little bit of confusion in the literature. So it normally deals with studying human actions. And its roots are not only in psychology, which is what most people tend to think, but also sociology, social and cultural anthropology, and also the behavioral aspects of biology, economics, geography, law, psychiatry, and political science. And it often seeks to generalize about how human behavior relates to how we operate as societies. And that's certainly my experience. So why is behavioral science relevant to the current crisis? I think at the current time, it's really important that governments in particular, but also intergovernmental organizations like the World Health Organization, try and influence citizens' behavior to deal with the crisis. And in May, there's a really interesting article in the New Scientist that proclaimed that behavioral science is absolutely central to our fight against the pandemic. And I think, as I've discussed before with Harry, who I know is listening, and others, Harry Campbell, the beginning of the crisis, I didn't really feel that I had much to contribute because I was not an infectious disease researcher. And but then I began to observe that actually a lot of the measures that were being taken to address the virus and the disease were behavioral measures. So there is something that those of us working in this area can contribute. So the New Scientist argued that the well-recognized role of epidemiologists, immunologists, and other scientists is limited unless we also factor in the science of human behavior, how real humans in the real world act and think. Our understanding is therefore incomplete if we don't look at that, and our attempts to defeat the virus will fail. So how can behavioral science support the COVID-19 pandemic response? So there's a number of studies looking at this now, and in fact we have a network of behavioral scientists around the world discussing new research and what's going on. But a single source I'd point to is there's an excellent article by dozens of authors led by Van Bavel and colleagues who wrote in Nature Human Behavior on this back in April 2020. And they use a framework which I'm going to apply to talk about the key contributions of behavioral science in terms of theories that we use, and then give you some examples. So the first thing to think about, and just think about how you've all responded to these past few months yourself, and think about the messaging from governments. And an important part of that is how we perceive threat. So in behavioral science, we look at threat perception, we study threat perception, and infectious diseases in particular are interesting here, because historically, of course, they've been responsible for the greatest human death tolls. So bubonic plague is one example, killed approximately 25% of the European population. Now the reality, of course, nowadays is that 80% of global deaths are caused by non-communicable diseases. But we're potentially much more afraid still of infectious diseases, and arguably research then has been directed to those maybe disproportionately potentially in the UK compared to NCDs. So we get negative emotions from threat, and negative emotions can be contagious, and fear can make threats appear more imminent. And studies show that strong fear produces behavior change. And in my own work, I've looked at, for example, visual health warnings on cigarette packs and how smokers respond to fear versus positive messaging. It's really, really salient. So if you think about threat perception in the current crisis, there's some good and bad things to do with that. If you look at the data from the COVID social studies that my colleagues at UCL are doing, but other data, you can see that older people are much more afraid, potentially justifiably. They're more likely to try and fully comply with guidance, and they're more likely to have a better understanding in some cases of what the guidance says. Governments have also conveyed fear in the crisis. And to give you a current example, they've been sending a very clear message that people should try and get a test if they have symptoms linked to fear about what will happen if we're not able to identify cases. But governments can also convey fear in a negative way or exacerbate fear, which can lead to feelings of helplessness amongst populations and potentially unrest. And I kind of think we're moving in that direction at the moment. A second area for behavioral science that's relevant to the current crisis is emotion and risk perception. And this also applies to things like health warnings and mass media campaigns in public health. But one of the things I think we need to think about in the current crisis is negative or positive framing. So the media generally uses negative risk framing in relation to lots of topics, not just this one. And they're absolutely doing that at the moment because that's what captures attention and that's what the media is employing. But that feeds into people having a misunderstanding or ignoring or not understanding what the probabilities of risk are to them. And we certainly see that in the current crisis. So in relation to people's limited understanding of who is more or less at risk, we may understand that working in public health, but the public generally may not have a fine or nuanced understanding of that. And also the media doesn't necessarily report that accurately. So do you see stories in the media about people who've had COVID-19 with mild symptoms and have recovered so far? Not many of those. There's also a strong emotion and risk perception element to how people are talking about children in relation to COVID-19, and crucially the return to school and discussing that in relation to risk. So that can contribute to real concern. A third area, there's about 5 or 6 of these, six or 7 of them actually, is prejudice and discrimination. So you'll know with previous infectious diseases and indeed pandemics, there's been strong prejudice and discrimination directed at those who either have the disease or are regarded as engaging in risky behaviors related to the infection. And of course, early in the pandemic, there was absolutely an issue to do with prejudice and discrimination, particularly from people from South Asia. We saw that in Europe, and also some governments, well, one government in particular has pointed to the sources of the virus, calling it a Chinese virus. So that is a negative aspect of prejudice or discrimination. But alternatively, you can channel some of the, both the fear and the concern about the virus into positive directions. So you can also channel feelings of collective identity, of solidarity, and of resilience. And I think a good example of that is the mass media campaign that the Scottish government has designed around Stick With It Scotland. I think most of us have seen that. That is trying to invoke not prejudice, not discrimination, but solidarity. Another area is disaster and panic. So there's a common belief in, there has been in the literature that people panic when they're in peril or they're likely to do that. And we certainly saw panic buying at the beginning of the pandemic in the UK when lockdown restrictions were being imposed, loo roll, etc. We all saw that. But if you look closely at the data about the evidence from crisis, close inspection shows that what happens in disasters is really quite different. Some people do act selfishly, and some who are particularly vulnerable may experience more distress. But cooperation and orderly norm governed behavior is actually much more common. And here again, you can see that in the UK, we've channeled both volunteering in the community, positive messaging about key workers. All of those things are not about disaster and panic, but more about pulling together. Social context is also a framework or something that we try to understand in behavioral science, very important. And slowing viral transmission during the current crisis requires significant shifts in behavior. And this is probably the area that I've been asked about most, and many of you, of course, and Uncover have been looking at non-pharmacological interventions, public health measures, which are behavior driven. So physical distancing, hand hygiene, not touching your face coverings, these all require changes in social norms and changes in behaviors. And I've been talking a lot in the media about the balance between guidance for behavior change and regulation. So giving the public messages that are evidence-based around what they themselves can do, these measures that I talked about, versus punitive regulation, which is the threat of fines or police action if people don't comply. And of late, of course, with the coronavirus acts across the UK, there is a strong element, there is a strong punitive element, and the media again tends to emphasize that. But experience from public health measures generally shows you that those punitive aspects are really rarely needed. And most people actually want to follow guidance, to comply with guidance. But they can increase compliance if there's a threat of action, if that doesn't happen. So the other thing, I suppose, just to emphasize in relation to social context, just a couple more points, is that a lot of behavioral science research has suggested that a large proportion of interventions can come not from the direct effects on people who receive the interventions, but from the indirect effects on their social contacts who copy the behavior. So in other words, when we started to use face coverings, I think some of us probably felt social pressure to do so increasingly, even before it became mandatory because other people were doing it. And of course, high profile figures can really increase compliance. Conversely, high profile figures who don't follow guidance can undermine compliance. And again, you see that from the social study, the COVID social study, that the Dominic Cummings effect, other leaders, in fact, there's examples all around the world of other leaders not complying and not following guidance and public trust being undermined. And then you can have high profile public figures, our First Minister in Scotland, who's not had a holiday all through the crisis, or others who can be good examples. So just a couple of further points. Social inequality has been hugely important during the pandemic, and I think the current crisis is really, sorry, apologies for my camera, it does do this. The current crisis has really shown how stark inequalities are, shone a light on some of those. And I know Gwynetta is going to be talking about ethnicity and ethnic minority communities, but just the basic aspects of, in a range of countries, who has access to resources to follow public health guidance, things as basic as hygiene, clean water. In the UK, we've talked about insecure housing, hunger, the use of food banks, and of course, now the very live debate about furlough and what is going to happen with unemployment. So behavioral science, again, can help us to understand all of those things. And two final points, which I don't have time to go into. The role of culture in countries has been important. So how cohesive is a society? How likely are they to follow the guidance of governments? It's often pointed that cohesion in some countries in Southeast Asia has played an important role in their ability to mount a public health response, not just their technical infrastructure, but also how they behave in relation to guidance. And then political polarization is also an important thing that we study in behavioral science, and how people respond to politics. And we're definitely seeing that in many countries around the world, and the pandemic has again shone a light on polarization between different groups in society and different political parties. You need to only look at the US, Brazil, and other countries to see that. So finally, just in relation to what I've been trying to do in recent months, particularly in the media, so science communication is a really important component of behavioral science. So the information environment around the pandemic really underscores the importance of effective science communication, not only just generally to keep the public up to date and to have a research input to the narrative, but also to address misinformation. And of course, there is misinformation about COVID-19 and about public health measures. It's important that researchers step up and do their part to make sure that that is not disseminated more widely than it needs to be. So I draw on behavioral science to help with science communication. That's what I've been doing in recent months. And even today, the interviews that I've done this morning for the media have been around the testing problems. Currently in the UK, I have no technical expertise in relation to the testing system, but I've been listening to what governments have been saying around people coming forward for testing when they don't necessarily have symptoms, or perhaps milder symptoms. And I guess the question I would ask there from a behavioral perspective is, well, if governments have spent months telling their public to get a test if they need one, then it's not the time to blame the public for doing exactly what they've been asked to do for really quite some time now. So those are just a few personal reflections, a little bit of drawing on the literature. I hope that was useful. And I just wanted to personally thank you for all the work you've been doing in Uncover, because I know how tremendously valuable that has been to policy colleagues and to others. So thank you very much.
Thank you very much. That was fascinating, especially when you touched on the testing issues that we see now in the UK. So we have, I'll start the questions. So the first one is by Nene Roa Duer, and she would like to see whether you can further develop your point about the way we are moving now increasingly more towards a situation where there is a feeling of helplessness and unrest. And what can we do about that?
Sure. So I made a few comments about that when I gave evidence to the Scottish Parliament COVID Committee. And again, that was data driven because I was looking at the surveys, and you can see that as we moved out away from some of the more restrictive measures, people's understanding of the guidance became more confused because the guidance was more diverse. And also compliance has declined, particularly since May. And the compliance is very different across different age groups, more in rural and urban areas, etc. So that's the first point I would make. The second point is that it's just the duration of exposure to the threat and to the unintended consequences of the pandemic that cause problems in terms of behavior. And when you have a crisis situation that goes on for some time, and then people begin to see the non-virus related consequences, so the unemployment figures that have been released today, for example, then it really adds fuel to that political polarization I talked about, where you have groups that have a very clear agenda about disrupting the solidarity and trying to sow distrust in government. And that's what we've seen with the protests, which have been very mild here in the UK. But you can see what's been happening in France in recent weeks with some of that increasing. So I have, I'm not as concerned that we're going to see some of the scenes we've seen in some countries, but I think all governments need to be prepared for the fact that there will be more problems in the months to come. And history tells us that from looking at epidemics.
Yeah, thank you very much. There's another question now coming into the chat. Sorry, I'm just going to read it from the chat. So in your research, that's from Maruk. In your research, have you noticed any difference in the behaviors of people of low income and high income countries?
So in terms of, so I've not studied this for COVID, although I'm sure there is data. There's certainly data, Maruk, on, if I just start with one point, on support for governments across the world. There's some really good large surveys that have been done on that, and that's highly variable. It's probably more to do with the historical issues to do with trusting government in those countries than it is to do with the pandemic. But in general, in other research that I've done in NCD prevention, you can see that people's ability to follow public health guides is entirely dependent upon the resources that they have available to them. So if people are living in low resource settings, they have less autonomy for their own decision making, they have fewer resources in the current situation, obviously, in terms of their living arrangements. Or just reflecting on some of the things we've heard from colleagues in the webinars that Usher has organised. When we had the one from South Africa, you could see that a strict lockdown was completely impossible for most of the population who were living in uncertain circumstances in terms of their income, and they had no choice but to try and continue their employment. So I think those inequalities around income between and within countries are really salient at the current time.
Thank you very much. So the next question is from Marshall Dozier. Marshall is asking about how public health behavior specialists think we should approach cognitive biases that appear to prevent people accepting health information guidance. And she's asking that from a health information literacy perspective.
Yeah, I mean, cognitive bias is a really important feature or concept. So how I've used it in my own research has more been around health behaviors, so alcohol, tobacco use, diet, etc. And there, the cognitive bias arises when people are effectively not able to think about how a situation relates to them and their own health, but rather they're more comfortable with thinking about other people's health. So risk perceptions around, well, I might be drinking at hazardous or harmful levels. I know that might have impacts in other people, but I might be lucky and I might be one of the small proportion whose liver is not going to be affected, etc. Or in my work in smoking and pregnancy, we've looked at cognitive bias in relation to women's beliefs about their risks based on, for example, knowing people in their family who had a healthy baby and smoke throughout the pregnancy. So these are really important concepts that are relevant. And I suppose in relation to the current crisis, yeah, there may be some of that going on. I've not seen any strong papers looking at cognitive bias in relation to COVID, but it's a very good question. I'll have a look for that. Thanks.
Thank you. I have one question as well. Now, you talked about the different perception of fear among different age groups. So what do you think the impact will be of that now that the universities are coming back across the country and students are coming from all over the world? Do you think that we'll see a significant impact because of that?
So I think that you only have to look at other countries in terms of the return of universities. So just to emphasize, the thing that will determine whether the return of universities is disruptive in terms of the number of cases or outcomes in the community is far less to do with what the students do, but much more to do with the national context. In other words, have countries managed to suppress the virus to a low level, in which case university life can proceed, in a more normal way. What we saw in the US, though, obviously, was universities reopening in August at a time when there were a high number of cases in the community, and students even trying to engage in environments indoors where things were trying to be kept as safe as possible for them. You still had a large number of cases directly linked to the universities, and you had some universities like the University of North Carolina that shut after just a few weeks of the students returning. So what do I think will happen here? I think that we're doing everything we can to provide guidance to the students living in residences, where I think that's going to be more risky than what we're going to do in educational settings where we have fewer students and we're trying to follow clear procedures. But there's absolutely no doubt that the more people are interacting from different households, the more risks there are. So we'll have to see. Final point on that, back to testing. These testing centres, the walk-in ones that the Scottish Government is establishing, the one in St Andrews already set up, the one in near Glasgow Caledonian by the end of this week, and then the one in Edinburgh and elsewhere. We're going to need those for students, so students are able to be tested rapidly. That's part of the response, I think.
Thank you very much. There are not any other questions that I can see in the Q&A chat. Thank you so much for joining us today, Linda. It was very nice.
I really look forward to the talks. Bye.
Thank you. So the next talk now will be about our rapid review on children's transmission, and that will be introduced by Dr. Amir Kyrolos, who is a public health specialty registrar and an honorary clinical fellow here at the University of Edinburgh. So over to you, Amir. Thank you very much.
Thank you very much, Evie. So I'm happy to introduce our next talk, which is on transmission of COVID-19 in children and in schools. It's an important question which has been at the front of policymakers' minds, with significant implications for children's schooling, children's development, and interactions with other children and family members. It's also clear that from the start of this pandemic that the dynamics of COVID-19 transmission in children is different to other respiratory infections such as influenza. So the Uncover review started as a broad overarching question regarding transmission of children, of COVID in children. However, we've looked at more specific sub-questions in terms of specific transmission in schools, the likelihood of children being infected as well as infecting others, and looking at documented contact tracing studies. So I'll pass over now to Wei and Zhongyu to present the findings of the review. And in the meantime, please feel free to post comments and questions in the question and answer box. Thanks.
Hi, ladies and gentlemen. It's my pleasure to deliver this presentation on behalf of all the colleagues on this work. I'm going to present the rapid review we have done, which focuses on the role of children in the transmission of SARS-CoV-2. This whole presentation will be completed by me and my colleague Wei. This presentation is divided into 4 parts. The first is about research questions. We performed a living rapid review trying to investigate the evidence of susceptibility and transmission risk of SARS-CoV-2 in children by synthesizing the latest evidence on the role of children in the transmission of SARS-CoV-2. It is critical to understand this research as to inform health decision makers about reopening schools, childcare facilities, and communities. Then we jump to the next. Oh, sorry, the PPT, the PowerPoint was not moving. Could you? Sorry, I'm actually on research question. Yeah, please move to the next one. Yeah, thank you. It is critical to understand this research as to inform health decision makers about reopening schools, childcare facilities, and communities. Then we jump to the next one, methods. Could you move the PowerPoint, please? The next page, thank you. We conducted search in several electronic databases, such as PubMed, medRxiv, WHO COVID-19 database. Our second update was completed on 21st June. The first one was in April. We included articles which report documented COVID-19 cases transmitted by SARS-CoV-2 positive children, indirect evidence on the potential of SARS-CoV-2 transmission by both symptomatic and asymptomatic children, cluster outbreaks of COVID-19 in schools, the proportions of children infected by SARS-CoV-2. However, we excluded articles that focus on clinical features and or treatment of pediatric COVID-19 cases without any information on transmission. In the process of screening and data extraction, we followed standard uncover methodology. TA screening was divided among all members, verified by a second reviewer. The first reviewer performed screening, while the second verified excluded studies. Data extraction was divided among all members and performed on a standard uncover Excel template used for all the reviews. Then we have results. Please move the PowerPoint, please. The next page, thank you. Then we have results. We identified 2,034 articles overall. 1985 studies were excluded as there was no information on COVID-19 transmission by children. In the first update, 16 studies were included in narrative synthesis and 25 were included in the second one. Specifically, 2 studies focused on COVID-19 cases transmitted by COVID-19 positive children. 21 studies focused on potential of COVID-19 transmission by children. 6 focused on the COVID-19 transmission in school settings, and 13 studies focused on the proportion of children getting infected. My colleague Wei will continue to discuss further about these results. Thank you.
Next slide, please. Thank you, Zhongyu. So I'm going to continue the study results. First, we found 2 studies reported document COVID-19 cases transmitted by SARS-CoV-2 positive children. First, a 3-month-old infant whose parents developed symptomatic COVID-19 7 days after looking after their infant, and 2 children who may have contracted COVID-19 from the initial cases at school or in New South Wales. The 2 studies indicated that children can transmit COVID-19 to other children or adults. However, these studies have a high degree of uncertainty because of the difficulty in tracking transmission chains. Next slide, please. We also found 21 studies investigated children's transmission risks of SARS-CoV-2 with evidence provided on the chance of them being index or secondary cases, the potential of fecal-oral transmission, and the possibility of asymptomatic transmission. So we found that children are not the main index cases in family clusters. And children show prolonged fecal shedding compared to adults, and in some cases longer than 4 weeks. Young children, and especially those younger than 10 years old, has statistically significant lower viral loads than adults, and asymptomatic children had lower viral loads than symptomatic children. Next slide, please. we found 6 studies investigated SARS-CoV-2 transmission in schools, and we reported 2 cluster outbreaks in Australia, New South Wales, and France was. And their infection attack rates were around 0.23% and 25%. And the remaining 4 studies in France, Paris, Belgium, Ireland, and Singapore indicated that the extent of any student to student and student to school staff transmission is still limited. Next slide, please. Lastly, we found 13 studies estimated the proportion of children infected by SARS-CoV-2. And according to the data for 29 countries, the proportion of children among all confirmed COVID-19 patients varies from 0.3% lowest in Spain and up to 30.8% highest in Argentina. And the data from these studies confirms that the proportion of children among COVID-19 cases is comparatively small compared to adults. Next slide, please. So the next session is the limitations and the conclusion. So the study has some limitations. First, the literature review and the data extraction was conducted by 1 reviewer per article because of the tight timeline. And a majority of the included studies are preprint and have not been peer reviewed. And we also have not performed the quality assessment, and we could not ignore the potential bias. And so in conclusion, based on the limited evidence, children are unlikely to have been the significant driver of the epidemic so far, and there is not any evidence here to indicate that children are at high risk of causing super spreading events in communities or school. But it is noted that the relative contribution of children to SARS-CoV-2 transmission may change with reopening of society and schools. Therefore, we are collaborating with a South Africa team to conduct a new living systematic review to investigate SARS-CoV-2 transmission in schools. And we run systematic search in 6 databases and 3 websites with entry dates limited from December 2019 and to the 14th of July. So our first update is up to the 14th of July, and a total of around 2,200 articles were retrieved, and 11 studies meet the inclusion criteria. So we found 6 contact tracing study and 5 seroprevalence studies, and we run meta-analysis to investigate the infection attack rates and antibody prevalence for students and school staff in schools. And we are now at the in the progress of writing up the paper. And next slide, please. So we also list out the 2 updates for our children transmission review, and they are all accepted by Journal of Global Health. And here brings me to the end of our presentation. Thank you very much.
Thank you very much, both Wei and Zhongyu. We'll now move on to questions. So the first question we have is from Barry, who asks, given the variation between student cohorts in ability to distance, particularly in preschool and primary school, firstly, both from themselves and teacher and the need for direct interaction and visualizing mouth movements, how can we minimize transmission between students and teachers in these younger age groups whilst not adversely affecting educational achievement and psychosocial well-being? So Wei, Zhongyu, or Evie, do you have any thoughts on that point in terms of distancing in younger age groups on the basis of the findings of our results?
I can start by giving an answer, and then Wei and Zhongyu can join in if they would like to add any points. So, I mean, as Linda said before, when I asked her about the university transmission, one of the main ways to do that would be to keep community transmission as low as possible. So the virus doesn't get in the schools and therefore it doesn't transmit. It's a very difficult trade-off between limiting the transmission in schools, but also maintaining the well-being of pupils, especially the younger ones, and also making sure that doesn't impact their education. So keeping the schools open and keeping them as normal as possible should be a priority, but all depends on the way the virus is transmitting in the community. I don't know if Wei and John, you would like to add anything more on that.
So based on our results from our school transmission, we found some paper reports that the non-pharmaceutical interventions in place in schools are the daily health reports, hygiene, face masks, social distancing, and minor interaction between classes, and also the suspension of sports activities and staggered recess breaks. So that's the interventions in place in schools.
Thanks very much for that. And I'll just follow on with a question from Nene, who asks if you can comment on the use of face masks in secondary schools in Scotland. Do you think this is a good idea?
I would say it's a really good idea because in absence of the vaccination, it's really important to apply the non-pharmaceutical interventions, and wearing face mask is one of the most cost-effective one. And especially for secondary schools, children are basically, children basically tend to, have more activities. So wearing face mask can, obviously to decrease the transmission of the virus if the virus is there.
Thanks very much. And I guess just to add a bit of context, I think older children are in many schools being asked to wear face masks in communal areas, such as halls and other places when they're going between classes. And I think the question still is around whether face masks for the duration of a lesson are feasible and of use. So I'll follow on with a question from Ruth, which is also related. So building on the answer to the last question, will you be able to look in a bit more detail at specific non-pharmaceutical interventions in schools in future reviews? And will there be enough data?
The answer is yes. So if the data is available, and we are also looking into the non-pharmaceutical interventions in place in schools. But based on our school transmission review, so we have found 11 studies included, and only 2 studies reported the interventions in place in school, and the information is limited so far. So.
Okay, so moving on to another area of interest, which is regarding the age of children. So one attendee is asking, what were the findings regarding transmission in schools when controlling for children's age? For example, younger children versus older children.
So we found one study in New South Wales, and the infection attack rates for primary school, secondary school, and early childhood education and care settings were around 1%, 0%, and 2%. So the peak rates were observed in early ECDC, and another study in Israel found that infection attack rates were higher in junior grades than in high grades. So the peak rates were observed in the 9th grade and the 7th grade. So based on the findings we found, so we would suggest that we should we would suggest we should put more focus on the junior grades.
Okay, and we have another question regarding age, which I think is related in terms of what age does the lower susceptibility and lower chance of being an index case in children remain true? And I'm not sure whether we 100% have the answer to it, but if you have any further comments, Wei or Zhongyu or Evie.
So based on the so we also found a large Spanish several prevalence survey, and so the several prevalence of COVID-19 was estimated to be around 3% for the children aged 5 to 9, and 4% for those aged 10 to 14, and 4% for those aged 15 to 19, and comparing with seroprevalence estimate of 5% in overall population. So I suppose this answered the question for the seroprevalence in different age groups.
Okay, thank you. And we have some more questions. And clearly this is very topical at the minute, with a lot of interest around some of the uncertainty and what evidence we do have. So we have a question from Lawrence. Do you have any explanations for the wide range of proportions of cases occurring in children, for example, from 0.3% to 13%? So that's regarding why the proportion of children affected is so wide.
Basically, there are more studies we found in the electronic databases focusing on like adult transmission. Actually, less studies actually focus on children transmission. So based on the studies we found, especially for the direct evidence we found, there is a significant bias within those studies. It's that the sample size is very small, and it varies between all the studies we found. So maybe that's the reason to explain why the range of proportions very like large, from 0.3 to 13%, because the one thing is the sample size is very small, and the second thing is like the studies which focus on the children transmission, which more is from, like, for example, this study basically talks about the adult transmission, but it also at the same time talks about children transmission. So the data we extracted from those studies are not really a lot reliable. Maybe that's the reason to explain this question.
Great, thank you very much for that. We have another comment and question. So one of our attendees says, I wish to know what you think of teachers wearing face masks and teaching. I was a teacher before moving to Edinburgh in Okinawa, which is hot and humid. It was not convenient and practical at all to teach while having a mask on. Is there any other alternative for teachers? And I think actually I may move on to the next question because I think we've probably answered some of that in terms of the other alternatives, given that we've talked about lowering transmission in the community and other things which can be done in school. But clearly the use of face masks is still one that the evidence is emerging on, particularly in terms of their use in schools. So I'll move on to the next question. Schools are open and best efforts are being made to keep the teaching day normal. However, the activities and events that bring schools, parents and communities together are not going ahead at the moment. For example, schools, discos, Christmas festivities, fairs, sports days, and so on. Should schools and local communities try to engage in these community events that normally bring everyone together, as well as serving purposes like fundraising for the school, or should they be avoided completely due to the risk of transmission? So I guess that's a question around apart from absolutely essential classes that are going on at the minute, what are the options for other wider activities, which are probably also important for childhood development, interactions, and learning?
So basically, based on the findings we found, the evidence we discovered, all children from all the ages, they're actually susceptible to COVID-19. So maybe without the vaccination now, it's better to avoid all the huge gathering groups or activities. And then children sometimes tend to be asthmatic carriers. So even though they have acquired the COVID-19, but they may be asthmatic carriers. So based on the findings, we would suggest that apart from the normal teaching sessions, it's better to avoid like other non-essential activities. It would be good for children and also parents and also for teachers at schools.
Okay, we have another comment and question, which is related again to face masks in schools. And again, I think maybe important to highlight that our review did not specifically look at face masks in schools, but I'll open this up again to our speakers just for their opinions. So the comment from D is, I have 15 and 17-year-old daughters, and their school has observed that they thought the majority of pupils would wear masks voluntarily when they returned in mid-August, but peer pressure meant that they didn't. However, once this became mandatory, there was a very rapid full compliance. The messaging was to protect all staff, please wear masks. So any thoughts on face masks and messaging for that in schools?
I think like basically it's very normal for teenagers, it's like especially for teenagers, like receiving peer pressure from each other. But I feel like maybe I mean wearing masks is kind of like became a new normal in the life, especially in school settings. So I would say it's quite it's not a very stringent policy, but it's a policy which is cost effective, which is the easiest way to protect everyone amid the COVID-19 pandemic. So maybe it's a little bit not very a good thing to do, but it's like a necessary thing to do. And as teenagers, from wearing face masks to protect each other, it's also a good opportunity for them to learn to be like responsible for each other.
Great. So I think we don't have any more questions from the moment, but from our attendees, clearly that's generated a lot of interest a lot of comments from personal experience. So we look forward to seeing what other evidence emerges in this area, particularly in terms of what interventions are feasible in schools. So finally, just to thank Wei and Zhongyu again for that presentation, and I'll just hand back to Evie to introduce our next session.
Thank you very much, Amir. Thank you, Wei and Zhongyu, for the presentation and the answering of the questions. This was a very nice session. So we're moving along now to the ethnicity rapid review. Dr. Gwenetta Kari, who is a research fellow at the Asher Institute, will do the introduction, and I will come back to do the Q&A session. Thank you, Gwenetta.
Thank you, Evie. Yes, so I actually just started as a lecturer of race, ethnicity, and health disparities in the Usher Institute. So my title just recently changed. So as early reports were released, it became evident that racial and ethnic minority populations in the UK were being disproportionately impacted by the COVID-19 epidemic, which is now a pandemic. This report was created at the request of the Scottish Government to conduct a rapid review of the currently available data and literature on how COVID-19 was affecting the Black, Asian, and minority ethnic populations. Today, we have two amazing graduate students who I had the pleasure of working with over the last 5 or 6 months, and will so in the future as well, on the Uncover report on ethnic minorities. Prerna Keshan, a current MPH student who recently finished her dissertation, as well as Kayla Otreshko, who just began a MSc by research, who's going to be working with me and Ellen. Thank you. I pass it on to Kayla.
Next slide, please. Gwenetta, thank you so much for such a lovely introduction. My name is Kayla Ostrishko, and I'm going to be presenting the evidence on ethnic variations in COVID-19 incidence and outcomes with my colleague, Dr. Prerna Keshan. Next slide, please. We work with a number of staff and students alike on the MPH and alumni as well. And we did this work over 4 different countries: Scotland, Guernsey, France, and the United States. Next slide, please. And to address this question about variation in ethnic and racial populations in regards to COVID-19, we asked 4 sub-questions on this review. The first sub-question addressed the differences in regards to outcomes for hospitalization, intensive care unit admission, renal failure, and death. And then we also looked at how the UK sat in line with this with other countries. And then our second sub-question addressed living and working conditions among ethnic groups associated with differences in COVID-19. And our third question focused on comorbid conditions. And finally, we finished up with looking at the risk and challenges faced by refugees and asylum seekers in the UK. Next question, please. Next slide, please. So we did this through the standard methods used by Uncover. We searched through PubMed and medRxiv, which contains pre-publication articles. And we did include comprehensive terminology related to refugees and asylum seekers, as this was an updated review from our initial one. And we did this review back in late April, early May. And we focused on population-based studies that included ethnic demographics, migrants, migration, asylum seekers, and all types of studies. However, we ended up excluding modeling studies and studies without ethnicity data, and we also excluded studies that were not available in English. As for screening, we used the standard Uncover methodology, as this had to come out quite quickly. And then we used quality assessment tools such as CAFS and the GRAY criteria. And we did find that the evidence of this literature review was moderate. Next slide, please. And so for our review, we started off with 740 unique records for titles and abstracts for screening. And this was parsed down to 189 for the full text. And then we finished up with 63 in the final narrative. We did exclude articles that had no ethnicity data or they were not in the English language. Next slide, please. So for our first question, we addressed the evidence for the difference in incidence and outcomes. We primarily used generic results, and we found evidence of statistically significant results for advanced respiratory support, renal support, and mortality after ICU admission for COVID-19 in BAME populations when compared to white populations. We also found evidence, statistically significant evidence when comparing this information to the 2017 to 2019 chance of admission to the ICU in regards to non-COVID viral pneumonia, and also in comparison to the general public. And finally, we found evidence about the demographics. Non-white ethnicity patients were younger, of a higher deprivation, lower rates of obesity and overweightness were found, and women that were involved were also recently pregnant or currently pregnant. And we also did find that critically ill patients of an Asian ethnicity did have a higher risk of dying compared to white patients. And then we began to address the disproportionate impact of COVID-19 on ethnic groups outside of that particular scope of NERIC. And we found in the UK, through a biobank sample, that unfortunately, people of a Black ethnicity, when compared to people of white ethnicity, experience a higher risk of infection. Furthermore, South Asians and other ethnic groups have intermediate risk when compared to white ethnic groups. Additionally, when compared to white men and women, Black men and women were 4.3 times more likely to die from COVID-19. In non-UK studies, we looked at the US primarily, and we did find that African Americans were more vulnerable to COVID-19 when looking at studies that covered multiple states in the US. Additionally, in one study in New York, we did find that in comparison to the previous year for ICU admissions, individuals from a Hispanic ethnicity had doubled during the pandemic in terms of admission rate when compared to the previous year during the peak of the pandemic in New York. And we did also find information about disparity in Norway and also in Spain. And this was in terms of risk. In Norway, Somali-born persons had an infection rate of 10 times the national average. And then there were extremely high risk ratios when we were looking at what's happening in Spain for non-white ethnicities. Next slide, please. So we began to address the living conditions, which is our second sub-question, along with working conditions. Overcrowding was found in multi-generational households were found to occur more frequently in BAME homes when compared to white British homes. The Townsend Index is a score that's used to address issues such as that. And we did find an indicator of interest, which was that the COVID-19 infection increased per risk for every 1 standard deviation of the index. Additionally, we found evidence about income having an impact on COVID-19 rates. So a pay gap is present for BAME persons in the UK when compared to white British persons. It can be as high as 20%. And in the US, which we found more evidence of this, in Orange County in California, individuals who are Hispanic and Latinx living below the median income had a higher risk factor. And all over the United States, we found that 25%, individuals who make $25,000 per year had evidence of a 46% risk of infection. We also found evidence in regards to the location in which one lives. 2 studies mentioned high pollution being a potential risk factor, particularly in regards to areas with atmospheric particulate matter of 2.5. And this was in Norway as well. And I'm going to hand over everything to Prerna now. Thank you.
Hi, everyone. So next slide, please. I'll be discussing upon the working conditions. Thank you. Occupation has definitely been found to be a direct determining factor for COVID-19 infection. And through the relationship between occupational social class and comorbidities, it has definitely impacted the disease severity and mortality of COVID-19. We found workforce data from the UK showing significant disadvantages and inequalities in the employment of the BAME groups, which suffered twice as likely as other white counterparts to be unemployed or in precarious employment conditions. And even the data from US suggests that areas with low rates of COVID-19 infections had more workers in managerial positions as compared to the BAME backgrounds who, despite representing nearly 13% of the working age force of the population, were only in 6% of the top management positions, thus missing out on most possible protective factors of these roles. Additionally, the BAME background individuals were found to be working in the essential workforce represented in occupations such as cleaning, public transport, and retail. Additionally, 40% of the doctors, 20% of the nurses in the NHS, as well as 17% of the social care workforce were the people from the BAME backgrounds as per the IS study database. And we found that the COVID-19 transmission essentially in the workforce of these individuals tended to be transmitted due to the essential working conditions, the poor socioeconomic status of these individuals, as well as the essential requirement of using public transport due to the need of traveling to and from the workplaces, thus affecting disproportionately, exposing these people from the risk factors of COVID-19. Also, a study in the UK showed that the ability to adopt and comply with certain protective measures such as self-isolation was difficult and lower in the Black and minority ethnic groups. And in other regions as well of UK and Europe, we found various kinds of non-compliance of the social isolation within the BAME backgrounds, as well as challenging conditions of workforce deployments in the US meat and poultry processing plants, where crowded working conditions may have had caused a high risk of transmission due to the communication of health and safety information to the workers, as well as an occurrence of a diverse range of primary languages spoken among the plant employees. Additionally, next slide, please. When we talk about the comorbidities, so the comorbidities are the pre-existing conditions that predispose to COVID-19 infections, such as hypertension, diabetes mellitus, and other existing cardiovascular diseases, as per various studies by Lee, Ruan, and Chen et al. The differential rates of these conditions in the ethnic minority populations has translated into poorer outcomes, as already been discussed by my colleague Kayla, that there exists a high risk of complications and death among the BAME backgrounds from COVID-19. And a British Heart Foundation survey found that South Asians, Africans, and African Caribbean UK populations are more likely to develop type 2 diabetes as in comparison to their whiter counterparts, and resulting in increased predisposition to COVID-19 risk factors. And another study in US also showed that heart failure patients found to be COVID-19 positive tended to be Black with multiple comorbidities and living in lower socioeconomic status communities, as per Carvalho et al. Next slide, please. So we studied the refugees and the asylum-seeking workers and migrants in a separate group among this rapid review, as these disadvantaged populations had suffered from the socioeconomic disparities, financial irregularities, and difficulties in obtaining places to live. And the risk factors of overcrowded accommodations resulted in clusters of COVID-19 cases, as per minimal 3 or 4 studies that we found in this rapid review, which showed that the individuals living within the asylum seekers as well as the shelters tended to be more commonly of the BAME backgrounds, and majority of these people lived in precarious accommodations of shelters, where even the shelter workers were predisposed to COVID-19 risks. And we also found data showing that the younger homeless individuals between the age group of 18 to 34 appeared more likely to test positive for COVID-19 than their older counterparts. They were more at a risk of not only the physical, but as well as the psychiatric pressures of COVID-19 pandemic. And this arena of research requires more detailed study, which is going to be explored in our upcoming forthcoming review of the following rapid review that we conducted on the ethnicities and migrants. And we also found that in US as well, there were clusters of COVID-19 positive cases among the asylum seekers as well as the residents, which contained more of the individuals from the BAME backgrounds. But the uptick rates of COVID-19 testing were variable. And additionally, the individuals in US, due to a tendency towards being undocumented migrants, tended to refrain themselves from getting tested or did not disclose their symptoms, which resulted in variability of the data. And therefore, depending upon the geographical locations of the studies that we found, the interpretation of the results can be a little varied. Additionally, the two studies that we found upon the refugees and the asylum seekers presented a very significant finding that these populations tended to suffer from non-COVID respiratory symptoms. However, these symptoms predispose them to relatively high risk factors of and exposures of COVID-19 outbreaks, and therefore tended to make these populations a targeted region for the governments to carry out their solutions among these individuals. But due to the lockdowns in various communities as well as all over the world, there was a difficulty in conduction of studies and a robust research among the migrants, refugees, and asylum seekers is still being carried out. Next slide, please. So to conclude, when we talk about the limitations of this rapid review, the overall quality of the evidence from this literature that we obtained was moderate. And this was due to the fact that the publications that we included in this rapid review were extracted during an ongoing conditions of this pandemic during the months of April and May. And these studies were mostly peer publications, and more robust data is being gathered for a further review to build upon the potential risk factors that we have discussed in this review. Additionally, the data from the previous studies of that exposed talked about the analysis being conducted in UK were limited in the confounding variables of age, sex, obesity, and multimorbidities. And there was limitations in the description of the data talking about the various solutions to the risk factors that majorly impacted these communities, making them more prone to the risk factors of COVID-19. But essentially, the risk factors that most commonly discussed among these community backgrounds included the barriers of overcrowding, lower socioeconomic status, poor sanitation standards of hygiene among the individuals, homeless individuals, asylum workers living in the overcrowded accommodations, and the health disparities in the occupational situations among the various countries, which results in targeted policy making changes that are required at various governmental levels to target the BAME backgrounds and take further actions in the future to combat such infectious diseases. Thank you.
Vernon and Kayla and Gwenetta, this is a very interesting topic, and that was a great presentation. So as we're waiting for questions to appear, I have a couple of, there is one. I will start with mine, and then I will follow with Nana's question. So when you were exploring the differences between different ethnicities, both in infection rates, but also in terms of severity and mortality, did you observe similar differences in children as well, or was that specific for older populations?
So none of the data that I remember seeing had anything particularly parsed out for children. In fact, it was actually quite difficult to find a lot of information specifically on race and ethnicity for adults as is at that time. When we do the updated review in the near future, we hope to find more information, and we do hope to find some of that parsed out information for children as well.
Thank you very much. I have one question from Nene. So you mentioned that most of the risk factors identified by this review still hold. Have any new risk factors been identified by literature since your review that you're aware of?
Gwinnetta, I don't know if you happen to know of anything.
Yeah, so since our first review and the update review, there hasn't been new risk. It's just really confirmation of what we found the first go around in terms of working conditions and living conditions having a huge impact on transmission and risk, as well as comorbidities impacting the negative health outcomes. Now there's more data on comorbidities that we didn't have before. Before we knew that, we knew that diabetes, type 2 diabetes was high among the BME population, but we didn't know, we didn't have actual evidence showing about the link between type 2 diabetes and more poor health outcomes. But now we have that data, so.
Mm-hmm.
Also cardiovascular disease, so I see those things working together, so.
Yeah. And have you seen any differences in the infection rates as we move along the pandemic? So were there these more significant in the beginning of the pandemic and now they're kind of tailing off, or is it similar rates now?
You want me to answer, Kayla?
I'm just trying to think, because I know in the US, they've started to really parse it out more. I know that particularly in here, there's a lot of conversation around Hispanic and Latinx populations, of course, Black populations as well. And I cannot remember off the top of my head which one has the highest rate. I do believe it's actually, no, it is Black populations in the US, because I believe it's around 30% for Hispanic and Latinx.
Okay. I have a question from Ruth. Do you think it makes sense to split future analysis into different ethnic minorities to identify specific issues driving inequalities in specific communities?
Yes, yeah, I will take that. Yes, absolutely. I think it's going to be more important for us to split up the ethnicities or the racial categories to understand what the driving forces are for these disparities. I think it's problematic the way we just clump everybody together, assuming that they're going to have the same experiences and the same outcomes. And what we know from this data is that the Black population was significantly different than the Chinese population, but yet when you say BME, it's all together, right? Mm-hmm. And so parsing those things out are going to be crucial to fully understanding the impact of this pandemic.
And to just piggyback on that, there's also the issue of clumping everyone together, regardless of if they come from an immigrant and asylum seeker background as well. I know a lot of data that focuses on Black populations in Scotland. I've found that everything is clumped together, regardless of that variation. It's going to be very different for someone who has been raised in Scotland versus coming in from a different country.
Right. I have one question about the specific studies that were included in your review. You mentioned in the end of your presentation that there are many limitations of the included studies. What were the main of them? And are you planning to do some type, or did you do some type of risk of bias analysis in your original rapid reviews, or is that something that you're planning to implement in the next updates?
Yeah, so when we did this, we did do a kind of a graded analysis on quality. So each section had a grade in terms of what quality evidence was available for working and living conditions, so forth. And going forth, yes, we will do more analysis. And the reason we had these grades and we set the data was said to be like low to moderate quality, because at the time we were working with a lot of gray literature, a lot of preprints, And so with the updates, hopefully we'll get done soon. With the update, we'll have more of the peer-reviewed literature to include.
Okay, thank you. There is a question from Lawrence. Some questions have been raised about the role of religion in influencing risk behavior, such as a desire to meet in large groups or resist injunctions to wear masks. Is this a dimension you have studied in relation to the link between ethnicity and religion? And do you think it is important?
So it's not been studied by us in terms of the link between ethnicity and religion. However, I would say tune into the indoor transmission review because they do talk about religious practices in that one, but again, not specifically in terms of looking at race and ethnicity element, but the behavior of being in a situation of that nature.
Yes, if I can add to what just Kayla said, because I was also part of the indoor transmission review. So the clusters as well as the studies that we found on COVID-19 in the indoor transmission regarding, they showed associations between different religious practices resulting in increased clusters of COVID-19 in various, not only ethnicity backgrounds, but different countries and their specific religious practices. And this has been shown in the news media articles to have been completely condemned. And but however, this created increased awareness, and the governments and the individual communities took positive actions, I think, in regarding to curbing the control of the religious practices. So yes, you'll get to know more about that in that review. Next.
Perfect. Right, so I don't see any other questions. So I would like to take the opportunity again. Thank you very much, you as well as all the presenters for today. So if we can put the final slide on and there. So please join us tomorrow where we have another very nice program, including our rapid reviews on face masks and indoor-outdoor transmission. And also our colleague, Ignazio, will give a presentation on face masks. And also on Thursday, we have the presentations on transmission and policy, where our Uncover manager will have a conversation with the public health director from Ganzi. You can find the recording of today's conference on the website that you see at the end of this page. And that's all from us for today. And thank you very much for joining us.